Well, good morning and welcome to our 14th annual Fabry Family Conference. And it's so great to see you all here. And I think we still have a few people trickling in. You'll see quite a few extra seats because what we couldn't pin down is how many of some of the volunteers that are going on to camp were actually going to be at the conference. So we have a little bit of space in here, but we still have a good number. So I'll show you the numbers of all the people that are coming to the conference and the camp when I do my, my presentation. So we have, if we can, I'm changing my slides. Let me see if I can work this thing. Good. So first, we appreciate your cooperation in doing antigen tests. And so it's important just to get us off to a good start, even though the riskiest place we can get COVID is on an airplane. So hopefully most of you masked and you came here safe, but already the antigen testing has paid off because unfortunately we have had a few positive tests. And so those people are in their rooms being supplied with meals. And we've worked those out to where a couple of people that affected, they'll be in the hotel until Sunday when they fly back, while their unaffected family members have gone off to camp. So we worked that out. But it was important to do, and we have saved more people from getting COVID by doing the antigen testing program. And if anyone begins to feel sick, have any signs of COVID, please go out, wear your mask, please go out and do a new antigen test so that we can ensure that everyone's safe. So just some housekeeping. Please refer to your agenda and stay on time so that we're already a little behind, so we're going to make a little time up. But just be respectful of the speakers who have our elite group of physicians and other speakers who have volunteered to come here and provide presentations for your education. We really, really appreciate what they're doing for us, but just be respectful of the agenda. Not especially, but it's important, we're going to do a group photo this year. So you'll see it on the agenda, and after lunch, come straight in so we can get the group photo done before volunteers go off to camp and people start dispersing to other parts of the country, world, camp area. So you'll see you have an evaluation form in your packet. Try to keep up with that as we go so you can recall the speakers and provide comments and provide what you thought of our talks this year, and that helps us build a better program next year. Rather than give long introductions for the speakers, we are going to introduce them and then let you look at their bios and in the speaker handout in your packet. So we'll keep the introductions brief just for the sake of time. And please do not have sidebar conversations during the presentations because you'll prevent other people from hearing what the speakers have to say. And if you need to have a sidebar, please take it outside and come back. And pick your children up from the Timberlake for lunch and then return them, whether they're kids or teens, and then return them to the Timberlake before you come back in for the afternoon session. You'll have one more chance to get t-shirts and raffle tickets on the first break, and then all that will go away. And also, as far as the industry companies that kept their tables behind in the hallway, they'll all close up after the first break. If you have questions, please raise your hand. We'll get you a microphone because many of us with Fabry disease have hearing loss, including me, and so they'll miss out. They have potential to miss out if we don't use the microphones. And one last thing. Also, all the camp volunteers we want right after lunch. What's going to happen is the group photo. We'll do the raffles. and then Victory Junction staff is going to come here to meet the volunteers, and before they go off to camp they go at early to prepare for the campers that are going later. This is who is here. So you can see the different categories at camp, the number of families. The camp holds 32 families. They have 16 duplex cabins, and each cabin has 8 beds, so we can hold 32 families from around the country. And occasionally we have a family from Canada or 2, but this year it's all U.S. families from across the country. Among those that are going to camp, 77 adults and kids have Fabry disease. So there are 58 adults and 63 kids. The qualification for camp is a child 6 to 16 with Fabry, and then the whole family comes. So the people that are just coming to the conference add to that base of the camp families. So then we have an additional 21 individuals or families with 33 adults and 5 kids, and 27 of those have Fabry disease. And then we have the camp volunteers. There's 2 sets of volunteers, community volunteers, so to speak, and industry volunteers. And so of the community volunteers, there's another 8 people with Fabry for a total of 36 volunteers. And then industry volunteers, which this year it is all Sanofi and KAC and one other small company, Data Registry Services. Erica is coming to camp. So that makes up the industry and Eric for a total of 54 volunteers. We had a couple of drop off, so that number might be still fluctuating a little bit. People had issues and were ready to come to camp, and just even yesterday a couple dropped off. So total attendees at the conference is 248. 248 minus the industry people that don't come to the conference and just go to camp. And speaker handout, you'll see, has 15 slots, 6 physicians who we're very grateful to have with us, 7 industry speakers, and 2 hosts, myself and Casey. And 112 total people with Fabry are here today. So your kids are in activity rooms, so I think you've all gotten that yet. And we gave you a sheet in your folder that says, here's where my kids are. So depending on their age group and their status, they're in all-day activity rooms in 3 groups. And from 10 to 12, we do chat sessions broken out by affected or unaffected and their age. So there's 5 of those going on from 10 to 12. Plus a couple of the rooms have the younger kids are in a different room where there's really no activities, but just doing no structured activities like the chat groups, but doing other activities with the nannies and tutors. Please refer, so you have that in your handout. And at the end of the day, just make sure you ask your kids what they did in the chat rooms, because they're doing some pretty cool things. So we have a lot of people to thank that are here. So we have some of the best, the most knowledgeable experts in the Fabry community and in the physician group speaking for us today. And we have all of the kids' chat session facilitators, which are mostly genetic counselors and a couple of nurses. And we have 22 sitters and nannies from a company called Jovi. That's who's watching the kids that are here in different groups. Thank you to for many volunteers who volunteer at camp. We normally have 60. This year we have, I think I said 54, because Victory Junction asked us to reduce our numbers so they have more beds for their staff, because we fill up the volunteer quota with community members. And thank you to Casey and Hannah, who helped me get all this stuff together for our conference today. These are our sponsors, the people that provide funding to make this happen. So you can see how they're listed in their groups, and then the table sponsors at the bottom. And just a trivia, I'm doing a push-up challenge, so I did 10 push-ups for my challenge at every table yesterday. And so I did 100 push-ups yesterday toward my challenge. And I do them in sets of 10 because I don't know how many I can do in a row because I was afraid to jinx my challenge, so I didn't pressure myself. But so that is our lineup of sponsors. Thank you to all our sponsors so much for allowing us to, helping us to have the camp. And in addition to this, there's many individual donors that contribute to providing the conference and camp. A disclaimer about what you hear. Don't consider anything medical advice. Make sure you confirm anything you heard before you act on it from your own providers. It's all excellent information, I am sure, and true, but confirm anything you hear with your own provider. With that, I am finished, and we are going to, and so what we're going to do is Casey is going to introduce all of the speakers except for, well, she's in a chat group. I'll come up and introduce those couple of speakers, and I'm going to turn it over to Casey. Thank you, Casey.
Stay here for a second. Jerry, stay here. And we would not be here without Jerry Walter. Please give him a round of applause for the 14th annual conference.
Thank you all very much. I love my job.
I've been told that there will be push-ups at camp on stage night. Great. All right. Well, we have a great lineup of speakers today. First up is Dr. Staci Kallish, who is an associate professor of clinical medicine within the Department of Medicine, Division of Translational Medicine and Human Genetics at Penn Medicine, and the Department of Pediatrics at the Children's Hospital of Philadelphia, or CHOP. As well as the Perelman School of Medicine at the University of Pennsylvania. Dr. Kallish is board certified in pediatrics, clinical genetics, and biochemical genetics, and she sees patients of all ages, children and adults with Fabry disease. Please welcome Dr. Kallish.
All right. Hi, everyone. Oh, there's there. Okay. Hi. I also thought we were going to see some push-ups on the stage this morning. I saw them yesterday, but I was a little disappointed we didn't see the first 10 today. Oh. I hope this doesn't mean I have to do them afterwards, because that's not happening.
I can't remember. I think I'm on, I've done 97 sets of 10. I won't count this one because I need to save a couple for camp. But we'll do my 10 push-ups right now.
This is why I love family conferences instead of scientific meetings.
Today is, what is today?
Friday,
No,
the 18th.
The 18th. Today is October 18th, and this is my unofficial 98th set of 10 push-ups. Still counts.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
I'll see you later, or I'll see you tomorrow.
Now I'm wondering where I'm giving my next talk and who I can talk into giving push-ups on the stage. So as you heard, I'm a geneticist, and we're going to talk about Fabry disease in adults. We're going to kind of do a little bit of an overview. You're going to hear from a pediatrician, another geneticist who works mostly with children, who will talk about children with Fabry disease. Then you're going to hear from a cardiologist, a nephrologist, and a neurologist. So we'll spend a little bit less time on those things. So some of you may have seen me talk before, and we try to come up with some really creative titles, and it was so hard for Fabry disease. So I'm glad to be here. It was the best we could do. My whole office tried to help. No, I brought a whole list. So we tried ChatGPT, and they were brutal. So the other options were Glamazing Adventures, a Fabry-tastic gene story, I can't even read my own handwriting, glorious tales of a rare disease, or a fabulous talk on Fabry disease. So we dumped them all because none of them were that great. Okay, so this is basically what we're going to do today. We're going to talk a little bit about an overview of Fabry disease and the spectrum of disease. We're going to talk about the multi-system nature, so all of the different body systems that are involved. We're going to talk about genetics and inheritance. And then we're going to talk about how we recommend monitoring and a little bit about management for adult patients. Okay. So you may know that Fabry disease is the most common lysosomal storage disease, we think, and is caused by a deficiency of a specific enzyme that's called alpha-galactosidase A, caused by pathogenic genes in a gene that's called GLA, which is why all of the GLA puns. We see accumulation of a specific chemical and all of its derivatives, and you may see these written as GB3 or GL3 or lyso-GL3, so these are all different versions of what's being stored in the cells of the body. It's an X-linked condition, and this is important because we know that most people have 46 chromosomes, which is where all of our genetic information is, 22 pairs that are numbered, and then X's and Y's. Most males have one X and one Y, and most females have two X's. And the GLA gene, is on the X chromosome, which means that most females have two copies of that gene, where one is affected in Fabry disease, and most males have only the one copy, which is affected if they have Fabry disease. We're going to talk a little bit more about inheritance, I think, towards the end. But we're going to talk about how this impacts females in just a moment. And some of the data that I'm going to show you and some of the data you may see from other people looking at long-term history of Fabry disease started before or as treatments were becoming available. So it's really important to keep in mind that the disease course has changed a lot in the last 20 to 30 years as Fabry-specific treatments have become available. Okay. So like I said, there's a wide spectrum of disease, and it ranges from what we call classic or early onset disease to later onset disease. So classic Fabry disease we typically see in males, and we call them hemizygous because they have only the one X chromosome, and in this case it has an abnormality in the gene. This is in males. If we measure their enzyme activity, it's less than 1% or very, very low. We typically see symptoms begin in childhood or adolescence. Later onset disease is usually defined by males who have low levels of enzyme but higher than the less than 1%. We may see onset later on, including sometimes in adulthood, and sometimes later onset or non-classic disease in individuals is segregated to one specific organ system, often the heart, but it may also involve multiple systems. And then females can range anywhere from having no symptoms at all throughout their whole life to having as many and as severe symptoms as the males. So the reason for that is X inactivation. So you're going to get a little bit of biology today. So I told you that females most of the time have two X chromosomes and males have one. And the way that we balance that in our body so that females aren't walking around with twice as much of certain gene products is that we tend to turn one copy off in each of the cells of our body. So when we start out in development and we're teeny tiny, one cell and then a small number of cells, embryos that have two X's will turn off one copy or inactivate one copy of one of those X chromosomes very, very early on. And that's a random process, and we call that X inactivation. Everybody always talks about the cats because the fur color in cats sometimes is some of the genes that determine fur color is on the X chromosome in cats. So you can see in this picture here, one of the orange and black genes in cats is also on the X chromosome. So it's a good demonstration. So you can see towards the left of that picture of the kitty cats, the male cats have only one X chromosome. So they either have a black fur gene or an orange fur gene, and the cats are either black or orange. In the female cats, though, they have two X chromosomes. So if both of their fur genes of this specific gene are black fur genes, then they're all black. If both of them are orange fur genes, they're all orange. But in cats who have one black gene and one orange fur gene, you can actually see the pattern in their fur of which parts of their skin have the orange fur gene turned on and which parts have the black fur gene turned on. So in females with Fabry disease, we can't see which copy of the GLA gene is turned on and in which parts of your body as easily as we can in cats. But we know that for some people this is fairly even, a 50-50-ish distribution. And some people have skewing where the normal copy is on in most of the cells of their body. And some people have skewing where the abnormal copy is on in most of the cells of their body. We don't really have a great way to tell which of your X chromosomes is turned on. And we certainly don't take pieces of, like every part of a female's body to determine. There has been a little bit of work, and there was one study that I'm showing you here that showed that skewing of X inactivation, so either towards one side or towards the other, occurs in a significant portion of females with Fabry disease, and that the proportion seemed pretty similar when they looked at different cell types or tissue types through the body. And they were able to show that the pattern of X inactivation does seem to correlate with disease severity. So these two sets of bar graphs are showing you disease severity scores. So on the left side is a Mind Severity Score Index, and on the right, the bar graphs are showing a different scoring system called the DS3. And so the white bars to the left of each of them are people who are skewed towards the normal gene. So they have mostly the normal GL gene active. And you can see they have the lowest severity scores. The middle gray bars are people who are pretty evenly mixed between the two. And then the black bars are the people who have more skewing towards the abnormal GLA gene, and they have the highest severity scores. Okay, so we think about, we're going to start talking about some of the body systems. And like I said, you're going to hear from a nephrologist, a cardiologist, and a neurologist, so we won't spend a lot of time on those body systems. But we know that we talk a lot when we talk about Fabry disease about the kidneys and about the heart, and so we have to talk about those things. So we know that in classic disease, protein spilling or proteinuria begins in childhood or in adolescence, and that it will be progressive and eventually lead to a decline in the renal function. So in males with classic disease, and this is again without treatment, we see that many of the male patients have start to have renal insufficiency or decreased renal function by early adulthood, and that almost all of the male patients will have significant renal insufficiency by their 50s. And this will progress to end-stage kidney disease without either a kidney transplant or dialysis. And these lines here just show sort of the progression. So you can see in the sort of top set of lines with the open circles, the protein beginning in the urine, and again, starting from sort of childhood or adolescence, and then the progression of chronic renal insufficiency is what that stands for, and then end-stage renal disease. We know that treatment can really impact outcomes. And so these lines, so I didn't tell you, the last one was from the Rare Disease Registry. This is from another registry study, the Fabry Outcomes Survey. So these are pretty big populations of patients. We know that treatment has an impact on outcomes. And so these lines here, the top two show female patients. And on the left side, you see people who started Fabry-specific therapy when their kidney function was good. And on the right side, people who started therapy after their kidney function had started to decline. So the top lines, you can see they're fairly stable. The red line is sort of the average. Everyone's kidney function declines a little bit all the time, every single year. But you can see that in females to the right, top right, that line is a little bit steeper if you have some kidney disease before you begin treatment. What's most notable is on the bottom for the male patient. So again, on the left is if you started therapy while your kidney function was still pretty good, versus if you started therapy once your kidney function had already significantly declined. And then we see the continued decline and the more rapid decline there. Okay. And then the other big organ system that I think people are concerned about and are worried about, in terms of illness and potential life-threatening illness is the heart. So we know that most males with classic Fabry disease will have some heart disease by middle age. And this is because we store GB3 in all different types of cells within the heart. The main feature that we talk about is left ventricular hypertrophy, or thickness of the left side of the heart, the part that pumps the blood to our bodies. And this also is progressive without therapy. We also can see changes on EKGs. That's the one where they put the sticky things on your chest and measure the rhythm and other heart rhythm differences. And we can see abnormalities on MRI. So this is from the registry, the Fabry Disease Registry again, and this data was collected around 2008. So people who had either been untreated for a long time or been treated for just the past few years. So we know that there are major cardiac events in a lot of people. These bars here show the males are in like the turquoise and the females in purple, showing really the age of onset of the first major event. And so in terms of major event, they're talking about heart attacks, heart function failure, or cardiac-related, like heart rhythm or cardiac-related death. And so you can see a significant portion of people are having significant events. In the males, this can be really mid-30s to mid-40s most commonly. And then in the purple bars for the females, shifted a little bit later, but also a significant people are having events. And then we can also see that early signs and then later signs. So we can see that there is some early signs and some progression or risk telling us that there are cardiac events coming. We know that without treatment, a significant portion of patients, both male and female, will develop left ventricular hypertrophy or thickness. And we see commonly high blood pressure as well. So on the left side, oh, these are really small. On the left side, we see the very, very far left is any cardiac sign or symptom, and then in the second set of the lines are left ventricular hypertrophy, and those little letters, the TMs and TFs, are treated males and females, and then untreated males and females. So you can see a lot of people are developing cardiac signs and symptoms, both males and females, certainly in people who are treated and also in people who are untreated. And then on the right, you can see what percentage of patient had any of these symptoms, so any cardiac symptoms, shortness of breath or heart failure, heart rhythm differences, things like that, that in patients, the dark bars are people who had left ventricular hypertrophy, so people who have heart muscle thickness are at higher risk for having other cardiac complications. I'm going to skip over this because you're going to hear a lot about cardiology, and I know Dr. Jerry wants to keep us on time. But we know that there's a lot of, these are combinations of many, many studies showing that depending on the population we look at, many people, both males and females, have significant cardiac disease. And then talking about the brain or central nervous system disease, we really think about two different types of things. We think about stroke risk, so we know that there's GB3 stored in the small blood vessels, which includes the small blood vessels in the brain, which increases risk of both stroke, and then TIA, which is a transient ischemic attack, or what you may recognize as a mini stroke. And that we also frequently see white matter lesions or white matter changes on MRIs of the brain. And these can increase with age. They're more common based on sex or the phenotype or the people who have classic disease. So we know that this is something that occurs, and I've heard someone in this room already told me, and I've heard this from patients before, about people, especially females, who are thought to have MS initially because of the white matter changes on their MRI. And so these lines here show survival free from stroke or stroke event, and the solid lines are males, and the dotted lines are females, I think. Yes, and then the black bars, the black ones are people who have late onset disease, and then the gray ones are people who have classic disease. So you can see people who have classic disease have earlier onsets of strokes, and then people with later onset, less frequent but still significant. When we talk about the nervous system, though, I think this is often what we don't talk about as much and has significant impact on patients, which is neuropathic or nerve-related pain. And so this is from a pretty big a study of about 130 patients. So when we talk about kidneys and hearts and even strokes, some of those studies are big, thousands of patients over many, many years. You'll see as we talk now about the nervous system pain and then all the other systems, the studies are much, much smaller, which may reflect as a medical system sort of our prior focus on hearts and kidneys and not all of these other things, which I hope we're starting to turn around. But we know that a lot of people who have Fabry disease are experiencing pain. So in this study, about half of patients, and it was more like 70% of male patients experienced some kind of nerve-related pain. And so this could be episodic, coming and going, or chronic, could be evoked by some specific trigger, or could be spontaneous. And then pain crises occur as well. You can see on the right sort of for the males and the females, and then for patients overall, what percentage have all of these different types of pain. We also know that many of the patients have more than one type of pain. Most people describe their nerve pain as burning, but they also use words like electrifying or squeezing or pressing or prickling or soreness. And then all of these graphs here show some other characteristics of the pain. So on the left in these lines show for each of the different types of pain that people described, where in the body they were experiencing it. So you can see hands and feet, which may not be surprising to you, are most common, but a lot of people are also describing arm pain, leg pain, back pain, abdominal pain. And if you look at the chronic pain, so the bottom of those bars, you can see again hand and foot pain common, but also leg pain common, back and shoulder pain, abdominal pain in patients experienced on a chronic basis. In the middle, so on the top, we have the frequency of how frequently people were experiencing each of these types of pain. There's no bars here for the chronic pain because that's there all the time. But you can see for people, this is anywhere from a couple of times a week to a couple of times a month, but for some patients, daily or near daily. And then below that, how long the pain is lasting. So the pain is sometimes lasting a few hours to a day or two for people, but you can see sometimes much longer. And including for the pain crises that in that red section there, you can see for some people are having pain crises that can last more than even a couple of weeks. So these are really difficult to manage. Pain is a symptom that can occur in childhood and can persist or can occur in adulthood. So on the right, you can see in the red are people who reported that they had pain as a child and still had it as adults. So that's a significant portion. Some of the patients had pain in childhood that actually got better, and some had pain that began in adulthood. Okay. So talking about GI symptoms, and again, these are from smaller studies, but this is another symptom that often begins in childhood or adolescence for patients. And we know a lot of people have a lot of GI symptoms. So we can see nausea, vomiting, diarrhea, bloating, abdominal pain, cramping, all of these symptoms. And so you can see here on the right side, sort of each of these symptoms and when the symptoms began for most patients. So again, typically around adolescence is the median age. So starting early in a lot of patients. And then the bars at the bottom show for patients overall in this study, and then also separated males and females or adults and children, how many people, what percentage of people were having pain. So you can see about half of patients are having any GI symptoms, abdominal pain being the most common. Quick word, we know that we don't talk a lot about the lungs in Fabry disease, but we know that they can be impacted, and so we can see shortness of breath, we can see wheezing, we can see coughing, we can also see sleep disordered breathing, and this can be either obstructive airway disease, which is where air kind of gets trapped in the lungs and looks and feels like an asthma kind of picture, or we can also see restrictive lung disease where the lungs aren't able to expand and contract well. So for people who are having respiratory symptoms, we have to always look for other things, but it's important to keep in mind that Fabry disease can be the cause as well. When we talk about hearing and balance, and we talk about them often together because they're controlled by two different functions of the same nerve that leaves our brain. So these are some information from two, again, smaller studies, because we don't talk about this as much as we talk about sort of the big organ systems that are thought of as more exciting, but these can have significant impact on patients. So we know, depending on the study, we look at somewhere between a third to half of patients with Fabry disease have hearing loss, and vertigo is also really very common. And the vertigo can be either intermittent, so coming and going, and it can be either spontaneous or triggered by certain activities. And then a significant percentage of patients experience both hearing loss and vertigo symptoms. So in a smaller study, in the middle here, about 2/3 of patients had hearing loss, and this seems to increase with age. Also, maybe somewhat improved with Fabry-specific therapy, and higher in patients who have heart and other brain-related disease. But we can see tinnitus or ringing in the ears in a significant number, and the vertigo again. And in this study, when they describe people who don't feel like they had hearing loss, still about half of those patients who said, my hearing is totally fine, actually had decreased hearing when they had audiology evaluation. The hearing loss is typically what we describe as sensory neural, so it means it's the nerve that's involved is really impacted. Most commonly impacts higher frequencies, so higher noises are harder to hear. We can also see this phenomenon of sudden onset hearing loss. So some of you may have experienced this or know people who do, where instead of being a gradual decline in your hearing, all of a sudden one or both ears don't hear as well as they used to. This can be really scary and also can sometimes get better. So it may not be permanent, but it is something that is known to occur in patients with Fabry disease. Okay. So we know that angiokeratoma also occur, and these are some pictures of them. So these come in clusters, and they're like pinpoint, tiny little skin lesions that are often either dark red or blue or black. And when we say they don't blanch, that means if you put pressure on them, they don't sort of turn white and refill, they just sort of stay present. They're most common in patients from either the belly button down to the knees. So in male patients, we used to describe that as a bathing suit distribution. I think that comes from before we recognized that females could have Fabry disease too, and their bathing suits might look different. But we can also see them in mucous membranes, so around the mouth and the lips, like you can see in one of these pictures here. There was a study of about 700 patients that found about 2/3 of males and 1/3 of females had angiokeratoma, and interestingly that they could and may correlate with disease severity. So people who have more of these may have more severe disease. Other features include sweating differences and heat and cold intolerance, which I probably don't need to tell most of you about. I love that they had a temperature regulating, table outside, both with fans and with blankets, so you can go back and forth depending on what you need at any given moment. So in this study, they found that about half of males and 1/4 of females had reduced sweating, and of those, so overall, 1/4 of the males reported no sweating at all. So this can certainly lead to heat intolerance. And we can see heat intolerance, though, in patients even who do have sweating. And then a small percentage of patients, and in this case more females than males, have hyperhidrosis, so have sort of unexpectedly increased sweating rather than decreased sweating. We can also see eye changes. So we typically talk about this finding called cornea verticillata, which is this sort of wavy or spoke and wheel pattern that hopefully you can see in the top and middle eyes there, where you see sort of that haziness and sort of that starburst pattern. Sometimes this is how patients are first identified. If a good ophthalmologist recognizes this in someone's eye and says, hey, you might have Fabry disease, you should get evaluated. We can also see tortuosity of the retinal vessels, so the blood vessels in the retina in the back of the eye. So I think you can see this most clearly in the blood vessel that goes kind of across the middle of that bottom picture, where it kind of looks like a really wavy creek. Our blood vessels should be much straighter than that. And then we also, I don't think we talk about nearly enough, can see osteopenia, which is low bone density, or osteoporosis, which is a more severe low bone density, more commonly in patients with Fabry disease as well. The reasons are not entirely clear. Okay, so I think the last system, and one that shouldn't be overlooked, is really talking about psychosocial aspects of Fabry disease. So we know that having Fabry disease does not just mean concern about kidneys and heart, but can really have impact on patients overall. And so fatigue is a really common concern and can be really significant and impact daily activities. Depression is common as well and can impact both quality of life and ability to complete daily activities. We know that for people who have chronic pain, reduced sweating, and then nerve pain or acroparesthesia, they are more likely to report depression or decreased quality of life. And then some of our colleagues who are even in the room did a study that showed that psychological treatment, which can be done by in-person counseling or video telemedicine counseling, can be helpful for people with Fabry disease who are experiencing these symptoms. I think in the interest of time, we may go through these quickly. But so patients ask a lot about life expectancy and what they can expect. I think it's really important, again, to keep in mind, so this is from the registry, which is a big study, almost 3,000 patients when this data was collected in 2008. So many of these patients were untreated for a long time because treatments weren't available, but there was a reduced life expectancy, especially in males who were in the registry at that point in time. So on the left in these lines, the males are on the top and the females are underneath. The solid lines are the US population overall at the time this data was collected, and the dotted lines were patients with Fabry disease. So you can see that the line for males is significantly lower, and they found an average life expectancy of 58.2 in the males compared to 74.7 in the population overall at that time. They did find that people who had later diagnosis, so were later to know that they had Fabry disease, were more likely to have died during this period of time. The bars on the right, again, for the males at top and the females underneath, show sort of which features were present in the dark bars, which are patients who had passed away versus patients who were still living. So again, I think that I think that this is changing over time with Fabry-specific therapy. Here, there's a question. Yeah. So the question, if anyone didn't hear it, is if the patients who had died specifically because of Fabry disease or other things. In this study, we don't have that specific data as to what the cause of death was for each of those patients. But it's a good question. Okay, so we're going to talk about some genetics, which is really, my bread and butter and what I do. So we talked a little bit before about the X's and the Y's, and so these show some of that. So on the left side, you see when a male patient, so here people who are green have Fabry disease and people who are gray don't. So the male patient here has his one X chromosome and it has an abnormality in the gene, so he has Fabry disease. So for a male person who has Fabry disease, they will pass on Fabry disease to all of their daughters and none of their sons. So the reasons are that the females in all cases have two X chromosomes. They always pass on an X. A male has an X and a Y, passes on one or the other. That X has the Fabry-related gene, GLA, and so this means that if you're female and your father has Fabry disease, you have Fabry disease because you have two X chromosomes, you inherited one from your father, and that was the only one he has. It also means if you're male and you have Fabry disease and you have children now or you plan to have children, you will give Fabry disease to all of your daughters. Again, it's that second X chromosome that makes them female versus none of your sons who have inherited the Y chromosome. For female patients who have Fabry disease, so on the right side where you see this female who has one X chromosome that's green and one that's gray, so one with an abnormal gene and one with a normal gene, and she has Fabry disease, every time she has a child, she passes on either the abnormal X or the normal X. And that means her male children and her female children all have a 50% chance of having inherited Fabry disease. That means if your mother had Fabry disease, you might have Fabry disease, but you might not. 50% chance. It means if you're female and you have Fabry disease and you have children, or you might have children in the future, you'd have a 50% chance of passing it on to all of your children. There are some options available, and we're not going to talk about them today, for family planning, for people who are still family planning or thinking about family planning in the future. Certainly we encourage people to talk with genetic counselors to make sure that they understand their risks and can talk about some of the options that are available to either avoid passing on Fabry disease if that's something that you're interested in, or to begin sort of early diagnosis and treatment. So how do we diagnose Fabry disease? Like a lot of things in Fabry disease, it's a little bit different depending on if you're male or female. So in males, we can use enzyme assays to actually measure the enzyme level. Or we can use genetic testing, which is sometimes called molecular testing, to find a change in the gene. In females, enzyme testing may not be accurate. So if a female patient has a low enzyme, then that makes a diagnosis. But because of that X inactivation we talked about at the beginning, female patients may have normal enzyme activity in their blood and still have features of disease. So genetic testing is necessary. Genetic testing, unfortunately, is not always 100% clear and can sometimes give us confusing or unclear results. And so sometimes we can use biomarkers in the blood and the urine. You may have heard of these. We sometimes talk about them as plasma lyso-GB3 or GB3 or urine, and that can help us determine if there's storage related to Fabry disease as well. So I might have mentioned earlier on, we know that there is a wide spectrum of disease, and there are some variants or changes specifically in the gene that we know a lot about. And this is a really common one. Some of you may have this specific variant or may know that you have this variant. We typically think about this as a later onset cardiac variant. So the population of patients I see with Fabry disease is entirely adults, and I looked, about 10% of our patients actually have this change. This is their mutation or genetic variant called N215S. I don't know if other people who mostly take care of adults have the same percentage. I kind of like it because 215 is the Philadelphia area code, so it feels like it belongs to us. So we know that this causes predominantly later onset cardiac disease. So the left ventricular hypertrophy can begin in males in their mid-20s to mid-30s, and then progresses with age, and is as severe as it is in people who have classic Fabry disease. But the clinical events are really mainly cardiac. So we see, occasionally, you can see 17% of males with this variant will have some renal impairment, but we rarely see the kind of progressive renal disease or renal failure like we see in classic Fabry disease without treatment. So in these graphs, you can see that people in red are the ones who have this N215S variant, and in the blue are the patients who have classic Fabry disease or Fabry overall, and these are free from events. So on the bottom, on the left, you see CNS or stroke disease, and on the right, renal disease, and you can see these things really very rarely occur in male patients who have N215S, and there's similar data for females that I didn't show here. Okay, so we have just a few minutes. So this is right now the standard recommended assessments. That was you telling. I didn't know if you had a question, Jerry, if you were telling me. Got it. So this is the standard recommended assessments for adult patients right now. And so you can see it's busy and there's a lot of things, but they really suggest kind of general evaluations, including an update with a Fabry specialist, checking on your medical history, an examination, asking about new symptoms, new family history, and then has a whole list of assessments for asking you about all of your body systems, and then periodically how frequently we should be doing things like blood tests and urine tests for kidney function, heart evaluations, things like that. I think that there's a couple of different ways to go about doing this. I think ideally you're able to see all of the specialists that you need to see who have experience with Fabry disease. But certainly I know that for many of you that may be very challenging or near impossible if you don't live in a big city or live in a place where there's a lot of people with Fabry disease. So some of the other ways to try to manage this may be to try to see at least one of your specialists as someone who has experience with Fabry disease. You could do that by saying, my personal preference would be a geneticist, because I think we're really the most comprehensive. And then see local specialists, and your local specialist can confer with your geneticist who has experience. You could also choose to see whichever body part for you is most involved. So if you have predominantly kidney disease, maybe you try to see a kidney specialist who has experience with Fabry disease and can help your local specialists. We also have some patients who will try to coordinate their care at major medical centers on the same day. So like for me in Philadelphia, we have some patients who live not, in North Carolina, but a few hours away, where it's hard to come see doctors at Penn, but we may coordinate 2 or 3 or 4 of their different evaluations on the same day, and they just kind of come down, hang out with us all day. We get all their things done to sort of try to minimize the travel back and forth. Okay, and then the last things that I wanted to talk about, so management. We know that Fabry-specific therapy, when we talk about it in adults, we always recommend it for classic males who have classic disease. We really recommend it for anyone who has signs and symptoms, or so any features of disease, whether they're male or female and have classic or later onset disease. I think it's also helpful and useful would give therapy to anyone who is interested in therapy, because we know that even if you don't have features right now, we can't predict if they're going to occur in the future. And then supportive therapy to prevent and manage all of your body systems involved is important. We're running a little long, but I thought this was sort of useful and important to look at. We're not going to talk about specific therapies, but this is sort of all of the and this is really the last thing I have, but all of the different types and strategies for treating Fabry disease right now. So towards the bottom, on the bottom right, you can see enzyme replacement therapy. So there are currently 2 enzyme replacement therapies that are available commercially in the US for Fabry disease. These are IV therapies that are replacing the enzyme that's not working. On the left in the middle, you can see a chaperone therapy. So there is a chaperone therapy that's available for adults in the US. Chaperone therapy helps if you make some enzyme, but it's made abnormally. This helps that enzyme get to the lysosome like it's supposed to, where it can still do its job. Because that medication has to interact with your own enzyme, it is specific to your mutation. So some people are eligible for this therapy and some are not. And then the other therapies listed here, so substrate reduction therapy, as you can see in this little picture, is in clinical trials, but not currently available in the US or actually anywhere for Fabry disease, but helps the body make less of the GB3 to be stored. So you're not making that molecule in the first place, so you're not storing, or as much of it, so you're not storing it. And then at the top, you can see gene therapies, and there's a couple of different ways to do gene therapies, but gene therapy is really introducing the corrected gene. So that's really all I brought, except for one last really bad pun.